for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of those and should not be interpreted to reflect official policy or position of any entity aside from possibly Cashlight Memorial Hospital and affiliate outreach programs. If indeed there are any, in fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Hey guys, we're back.
Hi!
Very enthusiastic, Stuart. Thank you.
I tried to interrupt you.
You're pretty good at that. So, of course, you're hearing the great Dr. Stuart Brigham.
That's
and,
right.
of course, our other co-host, Dr. Paul Williams. Hi, Paul.
Hey, Matt. How you doing?
I'm doing well. Tonight, we talked about advocacy and kind of like a potpourri of position papers, policy statements from the ACP, a lot of
You
kind
like
of
the
random pearls
alliteration
about
there.
the Affordable Care Act. We talked about social determinants. We talked about gender equity a little bit. And before we introduce our esteemed guest, Paul, would you tell them what we generally do on this show?
Well, happy to, as always. We are the Internal Medicine Podcast, and we use our expert interviews to bring you clinical pearls and practice-changing knowledge. Sometimes we do a deep dive up front and really get to know our guests, and then sometimes we don't, which is the case of this episode.
Our wonderful returning guest has been on, I don't know how many episodes now, 5 or 6 maybe, is Dr. Fatima Syed. Fatima, thank you for joining us, and can you sort of remind the audience who you are and tell them a little bit about what we're going to do on the show tonight?
Hey everyone, my name's Fatima Syed and I'm an internist in Durham, North Carolina. Did my training in Philadelphia and have been involved with the American College of Physicians for many years now. Today we're going to be talking to Dr. Robert McLean, who is a rheumatologist and internist in New Haven and the current president of the American College of Physicians. He's been heavily involved with Medicine Practice and Quality Committee and the ACP, as well as the Health Policy Committee, and is kind of their representative this year. So we're going to be delving into advocacy and what that means today.
And also joining us, I should mention, is Dr. Shah, another returning guest, kind of Fatima's partner in crime. He has a master's in comparative social policy, as do you, Fatima, right? And
forgot about that.
Yeah. So that's why they know so much about this. At such
I just assumed we all did. Yeah, so it kind of goes without saying.
And like Fatima, Deep has been on the ACP Health and Public Policy Committee and involved in some of the behind the scenes of writing these policy papers. So it's a wonderful crew we have to kind of talk us through some of this stuff. Stuart, did you have any puns you wanted to throw in at this point?
Sorry, I'm deep in thought.
Okay.
So no would be no.
So, Robert, let's start officially. Thank you for coming back on the show. And can you please remind the audience a little bit about yourself? Give them a one-liner.
Okay, super. Well, I'm a 56-year-old physician, practiced primary care and rheumatology for over 20 years, but now focusing more on rheumatology with a very strong interest in quality and safety where I spend other time. And I'm passionate about advocacy and the role that physicians can play in improving our dysfunctional healthcare system. And as a result of that, I got active in the ACP and I'm lucky enough to be the president of the ACP for this year.
Well, congratulations, Mr. President. We're very thrilled to talk to you. As an internal medicine podcast, you are our highest leader. So thank you.
I'm honored.
Well, we should get to it. Fatima, can you get us started off here with maybe a case scenario?
Absolutely. So let's talk about a 31-year-old primary care physician, has been in practice for 2 years. She's becoming increasingly frustrated with the EMR at work and finds the billing and coding piece particularly difficult. And I'm going to throw another case.
So the question is, what do I tell her?
What do you tell her, and what do you think is what's out there for her to do to work on some of these issues, or who's working for her?
Yeah, well, that's okay. That's a great place to start. So the first thing I'd say is that who's working for her is organized medicine is clearly recognizing this. Specifically, the ACP, the AMA is doing a lot in this space too. My bias is that the ACP stuff is really focused more on internal medicine, since that's what we stand for and that's who we represent. There are really, I think, a tremendous number of resources on the ACP's website. Not necessarily under advocacy, although that's our kind of title here, but under practice support, templates about billing, learning about billing. There is a lot of stuff to learn, and it really is challenging someone relatively recently into practice over how to do it and what to do it. And quite frankly, the complexity is probably what's driven a lot of physicians in their younger years into large systems and networks where a lot of people take care of some of those headaches for them.
Yeah. And Deep, I want to kind of bring you into this as well. Can you talk a little bit about, because since you're in a leadership role in a healthcare organization as well, of if you see this and what's out there right now? I've heard of initiatives of potentially coding changing and physicians being billed at the same level for outpatient visits. What's going on in the policy realm with this right now?
Well, I think when you talk about the new physician who's entering practice, most of us, at least I know I did, I was expecting the first couple of years to really be about getting my clinical bearings and making that transition from trainee to the clinical supervisor or the attending. But because most training programs, at least I can speak to mine, do not really talk much about what it's like from an administrative perspective, it sort of hits you like a ton of bricks when you first come out. And I'd be interested to know from Robert, sort of a lot of people who go into these practices, whether they join a large group or they join a private practice, community health center, or they join a hospital-based large system, you really just feel like you're drowning the first 6 months in the scenario that Fatima described. And how do we teach and coach people not only to advocate for themselves at a policy level, but also within their own institutions? And so as a young leader in our group, that's something that I care a lot about helping people make that transition. But I think we don't even have the tools and training of how to speak on our own behalf when we're entering these new environments and practicing. I'm sure everyone in the group can speak to their own transition.
Your point is very well taken. I think that, there's several angles to approach. From the standpoint of just surviving in practice and figuring out how do you bill and code visits, there's a tremendously steep learning curve. And I think that without, to some extent, finding a mentor, somebody that you can turn to with questions about different types of visits and when is it appropriate to bill a level 3 or a level 4 visit, or how do you use modifiers, all these real life things really become second nature over time, but it's not something that you learn in residency. And quite frankly, you shouldn't necessarily be spending time in residency learning that stuff necessarily, but it's critically important. And as I say, I think there are a lot of resources out there. The ACP website has a lot. There's probably others elsewhere too, but you learn it by doing it. And I think the questions that come up over what does documentation mean, what does coding mean, is something that you really need people to show you who've been doing it for a while. Now, on the advocacy angle, people should be aware that it is recognized that coding and billing is a tremendous administrative burden. And I was involved with the Medical Practice and Quality Committee for the ACP a few years ago when I was on the Board of Regents, when we put together a paper about reducing administrative burden, where we, as the ACP, decided that we needed some policy to help legislators, regulators, and also physicians understand the role of a lot of these headaches that people have. Because quite frankly, a lot of things that are currently administrative burdens are there for a reason. There are prior authorizations because in some cases people do things without going through the right steps, or insurance companies want to be able to say, no, you should use a certain formulary or not. I'm not defending those things, but sometimes the people who are paying the bills to some extent have a right theoretically to direct certain decision making. We don't like that, but that's kind of the world we live in. And some of those burdens are there for a reason, but some of those reasons have gone away. And the paper calls for payers and regulators to evaluate different things. And we classify these different burdens and administrative tasks, and we call them out very explicitly and say, these things need to be justified in this day and age. We can't just keep piling on more and more of these. So we have a little bit of a scheme of a kind of a diagnostic criteria for what types of burdens and tasks there are, where there are things that have a role, some things don't. All those things are not things that the doc should have to do. So a lot of this gets at who within a given practice site should be handling some of these. So it doesn't defend them in the least. It actually tries to give a roadmap for how to correct and improve them. Now, in terms of how to someone who's frustrated and wants to explain their energy or explain how to get things better in their group, I think that's just a matter of figuring out where and how to speak up, whether within their administrative site, figure out who's making the decisions, and in subtle ways express an interest so that you can kind of get pulled in. Most physicians, young or older, are very busy. And I think a little bit of interest and somebody who's done a little bit of homework and knows something about this, before you know it, you're going to be asked to help. And that's one way to get involved and to kind of then help become one of the decision makers that can help lead things for a small group, or, in my case, in advocacy, started that in my chapter. Next thing you know, you're, becoming a little bit more of a decision maker at the state medical society. And next thing you know, it's national. So all that stuff kind of builds over time.
So just wanted to throw something at you. So the Centers for Medicaid and Medicare Services were recommending that they contract the level 3 through level 5 billing in order to reduce the amount of paperwork. And I know ACP kind of came out against that. What do you think would be an appropriate way moving forward to help to consolidate even something as simple as that?
Well, it's a great example where ACP pushed strongly, and has been for a number of years, to decrease documentation burden. And Medicare CMS in the last couple of years has actually been probably more responsive, and has been quite a while, to truly trying to relook at things and make some changes. The problem in this case was they kind of mixed up billing with documentation. So the ACP's goal was not to compress code so that now you're going to get paid the same whether someone's a little sick or a lot sick. It was to say, how much do you need to document for a level 3 versus a level 4 versus a level 5 visit? The idea was not to compress the codes and simplify the billing. It was to simplify the documentation. So when Medicare came out and said, oh yes, we're going to decrease some of the requirements for documentation, like now if you have a medical student, their history can count for some of the documentation. I mean, there's some things that they did that were better, but we were completely against the idea of compressing codes, because we're cognitive docs and we see sick, complicated people, and we have to be able to differentiate a level 3 from a level 4 from a level 5 in terms of the complexity of what we're doing and how to bill for it. So we basically pushed back a lot on the code compression, as did the AMA and a lot of other medical societies. I'm not certain exactly if it's set in stone yet, quite frankly. There was kind of a lot of back and forth, and CMS kind of has these proposed rules and then final rules, and things change a lot over time. But I can tell you that the physician organizations push back strongly against compressing codes. That was not what we wanted.
And who's exactly at the table with these decisions? Like, what does that, for someone who's a resident or a medical student, like who's making these decisions? How do they come about, and how do advocacy organizations represent practicing physicians? Right.
Well, without getting too much into the weeds about some of the coding stuff, a lot of the coding determinations are made by something called the RUC, the relative, I can't remember what it stands for, Deep. Do you remember what the letters are? Whatever, it's called the RUC. It's through the AMA, but also related to CMS. And a lot of behind the scenes stuff happens with different specialty societies that are represented in that group, which meets, and the ACP has a seat or two at that table. Other organizations do. They make recommendations to CMS. CMS makes those recommendations. And when they put out things like proposed rule letters, which they do in like February, the ACP sends back a 24-page response letter explaining what things are good, what things are bad, as do other organizations. And then I think the final proposed rule, or the final rule rather, is I think expected out probably any day now. But a lot of it is relationship building. These organizations reach out, contact some of the higher ups at CMS, intermittently meet with them. I had the very good fortune just 2 weeks ago to meet with Seema Verma, the head of CMS, with a couple ACP folks and a couple other leading ACP physicians, where she kind of wanted to get our feedback on just some of the direction things were going. There wasn't really a specific agenda, but we were able to, I think, give some pretty productive feedback on some of their newer models that they were proposing for primary care. We gave feedback about the codes, that the documentation improvements that they're pushing are nice. The code compression is really kind of misguided. If they want things like telehealth and patient access to improve, they need to really rethink how that gets paid for. Issues around Medicare patients having copays for everything virtually is a real disincentive. So there are a lot of things that I think they're willing to listen to. We'll kind of see where it goes. But I would like to say that we're one of the organizations that has really pretty regular, very high level communications between our high level DC staff and some of the CMS folks.
That was a very thorough and helpful answer. I'm happy to be here with so many policy experts, but for the purposes of this episode, let's call me whatever the opposite of a wonk is, and just say that I don't know anything. You'd mentioned a policy paper before, and I think one question I had, and forgive me if this is too fundamental, but sort of I wanted to know, when those are written, who exactly are they for, and sort of what are they trying to accomplish? Are they to unify the body who they come from? Are they to educate? Are they directed at policy-making bodies? What is the point? How are they generated, and what are they trying to actually get done?
It's a very good question, and they really are they're multi-purpose. So the ACP prides itself on being an evidence-driven, policy-driven organization, and for the most part, completely, when the ACP wants to respond to something in the public space, whether it's a law, whether it's a policy, the ACP really will not take a stand on something unless we have policy that has been vetted and established. So all those different policy papers go through a very explicit process where sometimes it comes from governors, from the Board of Governors, because that's chapter governors, I should say, or members. Ideas get generated and then make their way, kind of percolate up through different bodies within the American College, and then they go to a committee, which is a wide representation of people from the Board of Regents, people from the Board of Governors, at-large members who are experts in a given area, and they basically go through evidence as what's addressing the question, and then they come up with a policy. And the policy is meant to educate. It's meant to take a stand, in some cases, publicly, in the public health space or wherever, the policy space. It's meant to inform our clinicians of what we stand for and why. It's meant to inform regulators of what we stand for and why. And it's meant to give us background for when an appropriate law comes up, we can support or oppose a given law because it does not coincide with our policy.
And that's a really great explanation, and sort of to kind of give some more background about how a bill becomes a law in the ACP world. Basically, we're a really large organization, and ACP has to represent certain topics, or at least it needs to have goals that it's following through on, and it's not going to do it without evidence. And so these papers that come about, I'll give you an example with some of the gender pay gap stuff. It came from conversations amongst members, amongst the Council of Resident and Fellow members. And then it basically went higher and higher up until there was a specific paper initiative that talked about where we stood. Similar with women's health. And I think that's a good segue to kind of talk to Dr. McLean about what are the main policy initiatives that you're focusing on this year?
Can I break in before we get to that? And this will, I promise, set it up. I just wanted to point out, Fatima, I saw your name on one of the 3 papers that I think we're going to be talking about just in the near future, and to point out that you started on the Council for Resident and Fellow Members. And I think that's like a very tangible way. Like if you're listening, I know there's a medical student council, right? And then there's a resident and fellow members council. So if you're interested in policy or think you might be, and you want to get kind of a taste for this, like it seems like, at least from my perspective, Fatima, that you, and I think Deep as well, as residents, were able to be in the room and helping make and shape some of these policies. Is that?
Totally. Deep, I'll let you talk about that.
Yeah, I wanted to get back to Dr. McLean's earlier point when he was describing sort of how decisions are made in this big medical complex across the country, and describing how this committee that's administered by the AMA called the RVS Update Committee. I mean, it's amazing. It's an acronym within an acronym that decides how all of us are paid for the work that we do. And even as someone who is pretty enthusiastic and knowledgeable somewhat about the process, there comes a point at which I feel like it's very opaque. And one of the really neat things about getting involved as a medical student or a resident or even early career faculty is you've got to start to learn how this process works at some point if you want to have a voice. And these are the ways that are available to us, at least through ACP, and almost every professional society that has a seat at the table now has equivalents for medical students and trainees. They are somewhat competitive, but you can always find a way to get involved, particularly at your chapter level, which is the state level for almost every single organization.
And I will say this, if you try to get involved in ACP as a medical student or a resident, and you don't get selected for the council, we will remember the good candidates. We'll remember the people who reached out to us, and you can potentially join different committees as well. But one thing I want to point out also is that how you get, you don't want to get involved in an organization that is only matters to itself, right? You want to be a part of an organization that's talking about issues that are relevant to the practicing clinician and are relevant to your patients as well, first and foremost. And so in order to do that, I think it's really important to get involved with topics that are, become your own content expert, if that makes sense. If you're a medical student who's passionate about residency seats, ACP is working on that issue. And look into the policy work that ACP is doing, look into the advocacy work at a chapter level. And you don't have to work with just ACP, work with other medical organizations, get involved in your local legislatures as well. There's plenty of ways to get involved. But I think you have to find sort of your passions and interests within yourself as well.
Yeah, if I could weigh in for just a sec there, I agree completely. I was going to say, while the Council for Early Career, the Council for Students, the Council for Residents, there are wonderful segues, and those voices are incredibly important to the ACP and have been for a number of years, to the extent that the chair of those councils actually sits on the Board of Regents, which is where kind of the major decisions get made. So those councils are key, and each of the local chapters has most of those councils, and that's an easy place to get involved locally. And I think in the chances of getting onto the national council are much greater if someone has kind of sharpened their teeth or shown interest at the local level. I agree completely with what Fatima said about kind of doing your homework and learning about some of these policies or issues. To answer, I think the question that Matt was saying, somebody said, what are the issues that are kind of hot? Well, there are things that matter. These are purpose-driven ideas, and you see them in the news all the time. I mean, we have to, as doctors, be having kind of policies and trying to help progress things, big problems that address our patients, things like the opioid crisis, things like how do we try to get a handle on different social determinants of health, and how do we measure that, and where do we have an impact on that? Things like access to care for not just poor people, but people who are otherwise being discriminated against, the women's equity issue, the LGBT, those different groups are sometimes uncomfortable for people because it feels like we're getting too political. But as physicians, we are seeing patients, and those people are patients. And so we feel very strongly that we need to stand up and advocate in the public arena around some of these issues, which we feel have public health impacts. So those are issues which, we're commenting on weekly. I mean, if people look at the ACP website, there's like a little news thing on the right side. I'm signing off on some public statement or letter on one of these issues at least once or twice a week. It's really, it comes up a lot. We sign on to some amicus briefs when some of these issues are being kind of addressed at state or Supreme Court levels. I mean, people listen to docs. And one of the things that's fascinating about advocacy, and you learn over time when you go whether to the state house or to Congress, docs have credibility. And we need to use that well. We can't take advantage of it too much. We got to be honest and truthful and evidence-based. But people are yearning for good factual knowledge, and they tend to trust us. And so I think that if we use that well, they tend to find us as credible sources. And so we tend to have a good bit of credibility in the political arena.
Fatima, why don't you take us, I want to maybe use the rest of our time. Why don't we go through a couple of the specific policy papers, and maybe Paul, Stuart, and I can ask some questions, and you all can kind of speak to the specifics, but maybe that's a good way to use some of the rest of our time here.
Sure. Do you have a preference on which?
Yeah, I wanted to know, the Affordable Care Act, is that still a thing? I heard it was I heard it was repealed. Is there any truth to that?
Yeah, so let's talk about that. So the Affordable Care Act is very much a thing. And there is a lot of rhetoric that goes on about what's staying and what's not staying and how it impacts people. And there's a lot of healthcare innovation points going on. But the reality is that one thing I say, I think every podcast, is healthcare is an evolution, and the Affordable Care Act is a part of that evolution that we have to accept that it is a part. And now we need to talk about how do we improve further, or further not necessarily the Affordable Care Act, but just further the evolution. So it's still very much a thing. That's a paper that I was involved in as well that you mentioned, Matt. And just to not take credit for things that I didn't write, these papers are written by policy experts who work for the American College of Physicians and are then edited, written, and reviewed by the various bureaucratic bodies and different committees and that sort of thing. So I don't want to take credit where credit's not due. But let's talk about some of the recommendations in this, and then I'd love to get deep involved, and Robert as well.
Yep.
But the first point that was the first recommendation is we need to strengthen the Patient Protection and Affordable Care Act, and that's sort of like a general assessment that will achieve truly universal health coverage. I think, Bob, we can say this. What is ACP's position on universal coverage?
So going back to probably the early 1990s, when the ACP first started to really get involved in some national health policy issues, the ACP has always stood for reforms that provide universal access to affordable health care for all Americans. And so that's kind of the ultimate goal. Clearly, the ACP endorsed the ACA back in 2009 or 10, whatever, because it did a pretty good job of getting us there. It was not a perfect bill. Clearly, it didn't address affordability issues enough, because quite frankly, if it had done that, it wouldn't have been able to pass, I think. But so we got a bill that was imperfect, but it provided accessible health insurance on the state exchanges and wherever to a lot of Americans who did not otherwise have it. It addressed the big pre-existing condition issue. And so as it's slowly kind of getting peeled apart, unfortunately, we felt that it was important to make a statement about ways that we thought things need to be done to shore it up. So things around stabilizing the health insurance market, trying to encourage states to expand Medicaid, since some of them are contracting it, increasing competition in the marketplace. A lot of the competition that was set up seemed like a good idea, but many states only have one plan in their exchange. That's not exactly competition. And also trying to help with funding needed to help educate patients that they still have the ACA available and how to actually enroll in the plans. So I think that kind of hits most of the highlights of what we put forth in that bill.
Yeah, I think the main points are that coverage needs to exist for people, and it needs to be affordable. And then there's certain sort of recommendations of how to get that, but those are the two main points that ACP is focusing on in this paper.
As a follow-up question, maybe you all can comment on this. One of the things that I saw in that paper was commenting on these sort of ACA non-compliant plans, which are now available. So why are those a problem? So that we had these healthcare marketplaces, right, where people could get these ACA compliant plans, but now there's supposedly non-compliant plans that are out there. Why is that an issue?
Deep, do you want to take that one?
Yeah, I think there are some plans out there called association health plans, and I think that might be what you're referring to. Which are carve-outs by the Trump administration to allow folks to buy insurance that may not have as broad coverage or cover all the services that we think or that the Affordable Care Act spells out that every health insurance plan should provide. Mm-hmm. And those are a carve-out or an exception that have been granted through orders from the Trump administration. So most people think they haven't been particularly successful, but others think that they may grow in popularity, and that if they do, then that would sort of undermine the principles behind the Affordable Care Act in the first place, because they wouldn't provide that level of coverage that we want everybody to have. It's one thing to have coverage; it's another thing to have good coverage.
Mm-hmm.
Exactly. Yeah. Like this, Robert. If I can just weigh in for a second, I think that's the big concern. And I'm not certain if the non-compliant plans, it's not just that they're not providing what was called like the essential benefit package. I think there's concern that there's just much less regulation around them, and that people are more easily, quite frankly, snookered into buying insurance that looks cheaper, but in the end is going to, give them huge high deductibles or co-pays or whatever, and lead to them being bankrupt just like they are now if they don't have insurance. So I think it's trying to have more truthfulness in the marketplace that is, continues to be lacking in many cases.
What are the arguments against the Affordable Care Act? Like, why are people trying to repeal it in the first place? I mean, I know it's probably a very broad question, but the only thing that I've heard, the only thing I've seen are the fact that the plans that are ACA compliant are, for some individuals, pretty expensive.
Well, I think there are issues where, one aspect of it, which I think kind of got reversed, was the Cadillac plan tax. So a lot of people have very generous health insurance through their employer, sometimes some very large companies. And I can't remember how exactly they defined it, but the feeling was that because of the tax deductibility of insurance through employers, it ended up being a significant, almost like tax break to the wealthier, and it was less of a level playing field thing. So one of the aspects of the ACA was actually to tax the companies that were providing such generous health insurance. So people who have really good health insurance are now being told by their employer, because of this bad federal law, we can't give you such generous health insurance even though we want to. So there was some pushback at that level. I'm giving you a very superficial view of it. That was one pushback. I think there's also just the societal, this reeks and smells like socialism. Mm-hmm. People use words, and as I've said in multiple tweets and columns, words matter. People have emotional reactions to words. They think that this is a big government takeover, yet they can't wait to turn 65 and go on Medicare. Come on. So that happens time and time again. I had a patient 2 days ago who's gone without health insurance, and now he has like a big tax bill because he's worried because he didn't pay for insurance. So he's paying the penalty. Yet I say, oh, that's really too bad. And he says, but I go on Medicare in 2 years. I can't wait. But I told you 5 years ago this is a horrible socialistic plan, and I wasn't even going to go there. But so there's this tremendous disconnect, and actually something that I would recommend. So now people are talking about Medicare for all. And what does that mean? There are all these different bills. There's actually a wonderful. One of the other podcasts I listened to beside you guys was one that I saw a few days ago on Kaiser Health News, and they have a podcast called What the Health. And there was an explanation from some great health reporters of the different Medicare plans, and they kind of analyzed what's the funding of Medicare. People don't realize how much private funding, or how much private insurers play a role in administering Medicare or in Medicare Advantage. But then on the other side, people don't realize that Medicare actually still has a lot of government funding. So people just don't understand where all the money is going to and coming from. And until they understand that, you can't really talk about it honestly. So
universal health care is not the same as Medicare for all, right? Yeah. When you sort of defined it earlier, you were saying universal health care is just means that everyone will have access to health care, not necessarily how they're getting it.
Yeah, universal health care is a concept, and how you achieve it is different. So I would say universal health care means everyone has access to health care. How that is achieved, whether it's through a tiered system, a national system where everyone has the same kind of insurance, like is being proposed with the Medicare for All, whether it's, different models. Universal coverage is sort of a catch-all term. And going back to the point about why do people want to repeal Affordable Care Act? It's not even necessarily about repeals. I think people want to evolve the healthcare systems. Obviously, things are political, and there's a certain party that passed this law. But the origins of it, Deep can go into this as well, are from the 70s and under different Republican administrations as well.
Like Nixon, right?
Exactly.
Yeah. If I go back that far, I'll never be invited on this podcast again. But I think there are legitimate criticisms from both sides about the law. And the question is, what is the physician voice in all of this? Mm-hmm. And how do we have a constructive voice in the current political environment, and what's actually good for our patients and what's good for our profession? On the far left, there are people who really feel like the law just didn't go far enough, and a lot of it just supported the existing healthcare industry and perhaps didn't go far enough to help patients who are in need of greater assistance or give them more choice. And those who are on the right side of the spectrum are very concerned both about the socialism, but also that eventually this will either restrict choice or restrict access to care. And what I would be interested to hear from Dr. McLean is, at this point where we probably all agree that the law is here to stay, what role do you see the large medical professional societies playing in making sure that the original intent of these laws is actually preserved, which is about access and coverage? Because that was what the law was sold on, which is right, increasing coverage. And now with the cost of insurance going up again, with plans that people do buy through the Affordable Care Act on their state exchanges, getting into a little bit of detail here, how do we help rein those things in?
I agree that really is a challenge right now. We have a law that kind of had some great goals that didn't really have a public option, so that kind of may have leveled the marketplace to some extent. So basically, from the get-go, there were problems where if it was designed as it initially was designed, it may have had a fighting chance. It was almost destined to have problems from the get-go because of all that. So it has had some problems, especially as the opposition party has kind of tried to peel it apart in the last 5 years. So given where we are now, where you have kind of a system that's kind of floundering, but it still has provided, insurance to, 20 some million people, I think was the last count, who did not have insurance before. One of the things that drives people is loss aversion. Once people have had insurance and they hadn't had it before, taking that away, by taking the system away, is really going to be hard. And I think politicians do realize that. So it's not going to go away immediately. It doesn't seem like it. And so either A, do we try to shore it up and fix it, which is kind of what this paper tried to say to do in the short run, or do we, in this political cycle, say, you know what, if we're going to be rethinking this, what do we do? Where can we go? And so, literally the ACP, we're constantly kind of thinking that, but I think we're going through a bit more of that with some committee meetings this summer of saying, is it time to put forth kind of a new vision for where we think we should go next? Quite frankly, let's kind of think a little bigger. We've kind of, maybe the ACA was kind of, health reform 1.0, and we need to get to 2.0. Clearly, it's a complicated world. There are tremendous vested interests between the insurance industry and pharma, the whole medical industrial complex. I mean, it is an animal, and any little change you make is going to make 5 other pieces shift a little bit to make sure that they still have a role. So there's definitely no easy answer, but what I can tell you is that the ACP is really thinking this through a lot, has been for the last 6 months and will be for the next few, as we're seeing if we can congeal something meaningful.
I think we all recognize that there's a lot of entities involved with the ACA and how much doctors are paid broadly. But I did want to get your thoughts and everybody's on some of the positions ACP has taken on the gender pay gap. And that seems like something that as a professional organization, we should be able to influence more directly, considering that a lot of our leadership are also leadership of large medical centers across the country. Mm. And, how do we translate the position that we've taken, and I'll let you elaborate on that, to actually improving the pay of our colleagues who are doing the same work we are?
And I want to give a shout out to the ACP CEO, Darylyn Moyer, who is one of very few female CEOs of the big medical organizations. AMA now has a female head, and our upcoming president of ACP will be female as well. Not that Robert's not wonderful, because he is.
Well, thank you. Jacqueline's great too.
And Ana Maria Lopez was our outgoing president. But it's really interesting how things come together in a time period of things that matter. So, to give some background on the gender pay gap stuff, that ended up being around the same time that JAMA Internal Medicine was talking about gender pay gap. And that ended up being a year before the Me Too movement happened. And now, on the 2-year anniversary of the Me Too movement, ACP is heavily involved in Time's Up Healthcare, which basically sort of is looking at the big picture perspective of women in this profession and what it means for us to be in this profession from a leadership standpoint, from a practice standpoint, from a health standpoint, and also from a salary standpoint. And I think it's great that we're talking about issues, but an evidence, we're all physicians here. We all believe in evidence-based everything. Are we making strides? And I think it's too soon to tell right now if we're making, what kind of strides we're making, from a bigger picture. But I'll say, as a first year attending out of training, it's nice for me to be able to lean on these men and women, as I approach my job, my first job in contract negotiations, and what to look for and what not to look for. And ACP actually does provide a lot of resources for that. But most importantly, I think the theme is not what ACP does or doesn't do, but having a sense of community is really important. So I would encourage, no matter where you are, build that sense of community, find those mentors in your healthcare organization, and find the good people and run with them. And don't get bogged down by the bad people. And if you find that the people that you're working with are sexist or racist or putting you down, don't work there. It's not a good place to be.
If you have an access to a Dr. Darylyn Moyer, that's very helpful. She is a mentor and sponsor to both Paul and I. And I was actually at her grand rounds that she gave in Philadelphia recently. And I think it was at the current rate, if we didn't do anything, the pay gap wouldn't close until like 2070 or something. Mm-hmm. It was some ridiculous number. But we have an episode from the July 24th with Dr. Jagsy from Time's Up Healthcare, and she had a lot of data that we still have a long way to go, but it seems very promising. And there's amazing things being done. So it's very inspiring to just kind of watch and do whatever I can to help support that.
Absolutely.
But we have to talk about it and talk about it a lot, and that's what's happening. To kind of Deep's question, how do you make change happen? And some of those people might be in those C-suites in different entities and large networks, and they need to be hearing it. And as I say, I think you can't make things happen in those entities unless you're there at that table. And a lot of those people are connected to or maybe have been ACP leaders. And the more we talk about it, the more I think likely change will happen. It is slow, but most change is slow. But I don't know that we can really be doing anything more. We are talking about it a lot.
Yeah. And also, I think it's important for us to talk not just about us as physicians, but also patients. So there was, and Dr. McLean, maybe you can talk about a little bit about the women's health policy paper that came out recently, and sort of what was the impetus for that paper, and what are some of the the salient points from it?
Yeah, so that paper, there were a number of different, and correct me if I'm wrong here because you might be more familiar. I think it came through one of the councils or chapters where there was an increasing frequency of state laws that were limiting women's access to healthcare, specifically reproductive healthcare. And while some might kind of frame that as an abortion rights kind of law or bill, I think that as physicians delivering care and recognizing that reproductive healthcare is more than just abortion or not, it's a whole spectrum of things. And when there are attacks on or limits on Planned Parenthood and other things that were happening, that the feeling was that we really needed to step up and say, this is not just a political issue. This is health and health care. And so as a result of that, we decided to kind of frame all that within it being an equal access to healthcare for, half of the population. Mm. And that's where that came from. Is that pretty accurate, Fatima?
Yeah, absolutely. I think so. And I think it's also sort of a call to action of framing women's health care as primary care as well. And that as, internists, we need to learn more, and we also need to protect the rights of women, just as Dr. McLean discussed. But we need to learn more and be better when it comes to providing health care to women. And I think that's the general gist of that paper. And it was dreamed up before there are a lot of political things happening to women's health care, and it came out in a time when all of that was actually happening. So I don't know how it happens that we end up having a paper that ends up being really relevant politically, but somehow that's been the theme the last few years.
If I could just make a quick comment about advocacy in general in terms of how things kind of take off. I mentioned earlier that one of the issues that we feel strongly about is gun violence as a public health issue. And that became a huge issue. No intent really from us. We had a public policy or a policy paper going back late 2000s about gun violence, about the effects of gun violence, and maybe we should be looking at this as a public health issue. And then we kind of put together, after some of the different events 3 or 4 years ago, a revised policy paper, which got a bit of press. And then after another series of shootings and tragic deaths, we put out kind of an updated comment or paper to that, whatever it was, last fall. And it was then, like a month later, right after there had been another one of these horrific shootings, that someone from the NRA said, what are the doctors talking about? They should stay in their lane. And actually a trauma surgeon responded on Twitter, and it became wildfire, saying, this is our lane. So all of that, this is our lane stuff actually was a response to the ACP's policy paper or update from the month before. and it just took off, and it was unbelievable. And I mean, I don't think the NRA has ever gotten such bad press. But it showed the impact that, from an advocacy standpoint, that physicians standing up for the right thing can have. And I think a lot of people really admired the ACP for that stance, became more aware of it, and I think became more aware of the ACP's standing up in the public health space on a number of different topics, whether climate change being a public health issue, the gun violence, a bunch of other things.
I think some of the concerns are more that, at least some of the concerns from the layperson are that some of these statements seem very broad in their scope and not specific in their execution. Like specifically about like gun violence, for example, what specifically was ACP trying to do at that point?
Well, I think there's good evidence. So there again, this is evidence-based. So there's evidence that people who have access to guns, not just criminals, have a higher rate of suicide in the home, of children getting injured with guns, mental health issues. I mean, so there were a number of different things that have has some evidence that access to guns increases, rates of violence, and so it was really framed as not take away all guns. It was not a complete gun control debate, so to speak. It was, we need to look at guns where there's certain safety features that need to be in place. Remove the big the magazines that have a lot. I mean, there's a whole lot of things there. There wasn't just gun access. It was public health, and it was also, we see patients who have been injured by guns. We see people who have emotionally been injured because their child died or their relative died. I mean, it's having a tremendous impact on the public health of our community, and so it was really very much framed as gun violence as a public health issue, and we need to address it as such.
And Stuart, I think you bring up a really good point about what is scope and what's not. And Deep and I have talked about that a lot. And Deep, I'd love for you to get in on this.
Well, I mean, most of the United States Congress is full of attorneys who have an area of expertise, but seem to be experts in everything. So there's no reason that we can't have strong, well-informed, data-supported opinions. And I think that paper was actually originally written in 2014, and it was just an update, I think, that came out in the context of all this that Dr. McLean was describing, where the surgeon from, I think he's at Hopkins, made a tweet and it sort of exploded. But what that really focused on were two important political things. One is patient-doctor confidentiality and privacy and the right to discuss gun violence in the home. And the second was on the actual morbidity and mortality of gun-related violence. And I don't think anybody would argue that those aren't things that we want as a professional society. One, to be able to discuss whatever we need to for our patients' health and safety. And the second is the actual morbidity and mortality. And I think that's a very elegant way it was framed. Similarly, in my home state of Georgia, there was recently a bill passed in the legislature and signed, the heartbeat bill, which many of you may have seen in the popular news. It's an abortion bill. But a lot of the medical societies here took a position on it that normally would not, because it basically criminalized physicians for performing any act. So while they may not have taken a specific position on abortion, they did take a position on how it affects physicians and their relationship with their patients. So that's why I think in terms of scope, I certainly am someone who believes that until we have our financial house in order as a profession, that should be where we put most of our time. But there's no reason we can't have a qualified voice on several other issues that affect our patients.
Yeah, no, Deep. I'm glad you qualify it that way. It is a lot of what's underwritten. Some of these positions was laws or potential laws to prevent or to interfere with the physician-patient relationship and what could be talked about or what could or should be done. And I think a real major objection was government interference in that. Mm-hmm. The government should not be telling us what we can or cannot discuss with our patients. The gun gag rule started out in Florida several years ago. They tried to pass a law that you can't ask about guns in the house or whatever. And that kind of started several years ago. So all of these things have kind of built together, but it really is, it's framed not to make these political issues, but to put them in the context of who we are as physicians, what we're trying to do in taking care of patients, and how these various laws might affect our patients.
I think one of the big things that matters is physician autonomy. Autonomy is really important to us as a profession, to all of us as a profession. So political leanings may be different, but we want to work to protect each other's autonomy. And I think that is that's regardless of what the stance is, ACP or any organization takes, the stances it takes are for the best interest of physicians and for patients, but also to protect each other, if that makes sense.
And Fatima, I think we're out of time. Can you bring us home? Maybe if you want to throw take-home points, ask Robert for take-home points, or if you want to, however you want to bring us home here.
Absolutely. Dr. McLean, can you give us, your main advice and takeaways on what exactly advocacy is and how the practicing physician can get involved?
So I think I'd start off with, I would kind of define advocacy as taking a position in the public space on behalf of a meaningful issue. And that can have a broad spectrum. I think that what effective advocacy is trying to figure out how to make that taking of a position actually have an impact. And that involves getting involved with legislators, policymakers at the state level, at the national level. I think when people are concerned and want to know how can I stay informed on these kind of things, I think quite frankly, one of the best sources of information that I think is fairly readable to people who aren't too sophisticated is the ACP's government relations director, Bob Daugherty, who has a blog and writes a column in the monthly ACP Internist. He's been doing this for the ACP for 25 years, and I would say I rarely disagree with him. And his blog posts are absolutely phenomenal on really giving a pretty good sense of what's going on in DC and how to make sense of it from the standpoint of what is usually reflective of ACP policy. It's hard to keep up, but I think there again, people need to keep up. They need to find news sources and at least touch the surface on some of these issues. And also, as we had mentioned earlier, the ACP's kind of policy compendium on the web is a treasure of public policies. If someone were to read through the last 5 years or 10 years of policy papers, they would effectively have the equivalent of an MPH of education, but just no letters after their name.
Deep, did you have any final comments?
Yeah, I just want to say it can be a lot of work to participate in advocacy, and sometimes you don't see the fruits of your labor for several years, and you're just one voice in a big physician community, but it does mean a lot to legislators to hear from doctors at the local level, the state level, and federally. So all of this stuff is related. Physicians are trying across the country to preserve their autonomy. And I think that's a unifying theme for a lot of the work that we do. We want to, one, put our patients first and take care of them, but second, also maintain our sanity. And I bet in some way we could bring all of ACP's positions back to those 2 points. So stay positive, and I think that ACP and a lot of the other professional societies do amazing work, and you can have a real impact as soon as you're ready to get involved.
Yeah, if I could just say one more word. So I've people have asked me, why are you so involved in advocacy? And I have come to realize in the last few years that it was my burnout prevention. Mm-hmm. Talk about people needing a higher purpose and meaning, and taking care of patients and curing them and making them feel good is unbelievably meaningful, and is like the greatest honor to have that opportunity to do that for patients, but it still is sometimes really frustrating and tiring. And being able to kind of be involved at a higher purpose, meaningful level is just tremendously invigorating, especially when, and I've been lucky, I've had a couple opportunities where, I maybe had contact with a legislator or a regulator, and I made a difference. I impacted, I think, someone's opinion, sometimes, especially at the state level. A lot of advocacy and getting involved is preventing bad things from happening. There are a lot of really bad, not well thought out bills that are in state legislators. And if it wasn't for the state medical societies and physicians involved helping legislators understand the bad ramifications of things, there would be a lot of bad laws passed. So it's hopefully being there to help good things happen, but you got to be patient because a lot of the time is preventing bad things from happening.
Mm-hmm.
Fatima, do you have anything else before we go?
I think the big thing is we don't all have to believe the same thing, but to care about our profession and to care about our patients. So don't feel turned off by certain things that any medical organization is doing, and don't think that everything that you think is going to be the policy of the American College of Physicians. It's not. We thrive on having a diverse membership, and so get involved wherever you are in your local organization, your local chapter. It's a good place to start.
Great advice.
If you believe medicine is a calling, that means that your profession chose you. You didn't choose your profession. So then it's like your family and you have to get along no matter how much you disagree. So
now everyone hug.
Yeah.
I don't hug.
Paul Williams would love, if you ever see Paul Williams, run into him, please give him a hug.
Do not.
Do not hug.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy. Ish.
Get your show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
That's right, Paul, because we're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on iTunes or contact us at thecurbsiders@gmail.com. A special thanks to our producer for the show, Dr. Fatima Syed, and to our social media team, Hannah R. Abrams on Twitter, Beth Garbs-Garbatelli on Instagram, and Chris Chumanchu on Facebook. Until next time, I've been Stuart Kent Brigham.
And I would like to thank Dr. Deep Shah, who had to leave before our sign-off tonight, but serving as co-host tonight and co-expert, I guess. Until next time, I've been Dr. Matthew Frank Watto.
And I've been Dr. Fatima Syed.
And our main Dr. Paul Nelson Williams. Thank you and goodbye.
Oh, hi, Paul.
Classic stuff.
That's going to be the latest. Give Paul Williams a hug. We're going to be at a lot of meetings this year, Paul. See how many hugs.
Dr. Word deodorant.